Welcome everybody to tonight's Q&A on the kidney. I thought we would start off, first of all, just reviewing a few things. As I've said in previous lectures, it's very important to know what your kidney function is, both yourself and your family, whether you have normal kidneys or not. And we have a blood test that has been used for years and years called the serum creatinine, which you've probably seen on your medical records. And the serum creatinine gives us a pretty accurate assessment of a part of the kidney function that we call the kidney filtration. So the kidney filters your blood and gets rid of things that shouldn't be in the blood. And when the filtration process declines, the creatinine goes up. So it's sort of, we call that inversely related. As the kidney filtration, or what we call the kidney function, which is not a very accurate term because there's many kidney functions, but the filtration function specifically, as that declines, the creatinine goes up. And based on the creatinine, we can then get a rough idea of what that filtration capability is. Now, in the last 20 years or so, there's another term that is in your lab reports called the eGFR that you might have seen. And it's confusing because you don't know whether it'll look at the creatinine or whether it'll look at the eGFR. But the concept is that the eGFR is a calculation, not a measurement. It's not a blood test. It's a calculation based on the measured creatinine level in your blood. So the lab takes the measured creatinine, which is one of the many results from your blood tests, and puts that creatinine automatically into a formula. And then the formula spits out the eGFR. And the eGFR is another way we assess the kidney filtration, but it's not a measurement. That's the first thing to recognize. And number two, it's not a definitive measurement. It can be off by 10, 15, 20%. And so it's important to be aware that when your eGFR, let's say, comes back at, I don't know, 60, that number can be off. It could be really 70, or it might be 55. There's a range. It's not an actual measurement. Now, we and others are working on getting an actual measurement of the GFR. The E stands for estimate because it's been recognized for 20 years. It's not the true GFR. GFR is an acronym that stands for glomerular filtration rate. The word glomerular is in there and not just the word filtration rate, because the glomeruli are the parts of the kidney that do the filtering. The name of the filters are called the glomeruli. There's 1 million in each kidney. They do.
Wow.
So that's what the G in the GFR comes from. The F is filtration, R is rate, because it's measured over a period of time. There's a time component. That's where the rate comes in. And the E at the beginning, the little e, stands for estimated. And again, it's not a definitive number. Now, the other thing that evolved in nephrology was taking that eGFR measurement and putting it into what are called stages, or CKD stages. So it's confusing. We have the word creatinine, we have eGFR, we have the term CKD stage. None of them say anything different. That's the paradox about all of this. It's just, they're all different aspects of the exact same thing, how much your kidneys are filtering. And what happened a number of years ago is the doctors decided, rather than just give you what the GFR is or the eGFR, they would put you into a stage based on the eGFR number. So there's 5 stages, and the first stage is the least effect on your eGFR, and stage 5 is where, the eGFR has gone down to less than 15% of normal, roughly, if you want to think about it. And when you get to stage 5, you're getting close to needing what we call renal replacement therapy. And by that, we mean that when you get to the stage 5, your filtration is declined such that the kidney cannot keep up with the needs of your body or to maintain good and normal health. And we have to come up with another way to compensate for that. And currently we have three approaches. Either you go on dialysis, which there's two types, either hemodialysis or peritoneal dialysis, or you get a kidney transplant, or you do nothing. I mean, there's some people that refuse to do anything and they're just treated conservatively. And you can live for a number of years without dialysis, even though you really need it. There are patients that just, for a number of reasons, don't want to deal with it, or they feel that they've reached a point in their life because of their age where they can't even psychologically think that they're going to go on this treatment now, and they don't want a kidney transplant, or either because they're worried about the immunosuppressive drugs, or they can't find a donor, or they just don't want to deal with it. So there are many, many reasons why people don't want renal replacement therapy. But in general, your body can compensate and you can maintain fairly good health until it gets down to around 15% of normal, or what we call an EGFR of less than 15. The reason the percent and the EGFR sort of match is because the normal EGFR is around 100. So you can either say that your EGFR is 15 or you're 15% of normal when you get to stage 5. Now, the other thing to realize is that not all people follow the trend of going from stage 1 to stage 5. Many, many people get stuck at a certain stage, which is great. And in fact, that's what when you come to the renal clinic, or you see a nephrologist and you have a certain CKD stage, our goal is to, at a minimum, keep you there. Now, many times we can't reverse the abnormality in the kidney because there's been a certain damage. So we can't take you from, let's say you come in at stage 3, we can't bring you back to stage 2 or stage 1 or even normal, just because there's irreversible damage. But what we hope we can do is we can at least slow down the further decline in your EGFR, or another way of saying it is prevent you from going to stage 4 or stage 5, or another way of saying it is prevent your serum creatinine from going up higher. And so we try to lock you in at that stage for as long as we can. And you can stay at stage 3 for the rest of your life. You can stay at stage 2 for the rest of your life. It's only when you get to stage 5 that we really start seriously thinking that it's highly likely you're going to not stay at stage 5 for more than half a year or a year. I mean, every person changes at different rates. And as I said, many people just stay at a certain stage and they're fine. Each stage requires different types of approaches depending on what stage you reached, because each stage affects different things in your blood. So for instance, your potassium tends to go up at a certain stage, your phosphorus tends to go up at a certain stage, your blood pressures tends to go up at a certain stage, you become anemic at different stages. All these can be treated with drugs and without the need for dialysis. So we tend to start talking to people about the need for dialysis or a transplant when they reach stage 4. Some doctors discuss it even earlier. That can be inappropriate and can scare people because, as I say, if you get to 3, you can stay at 3 for a long, long time, potentially. So that's sort of how we assess the filtration components of the kidney, or the filtration function of the kidney. The kidney has many functions. The filtration is because the kidney gets rid of many substances from your blood. It gets rid of, as you can imagine, water. You see that as urine, but it also gets rid of salt. It gets rid of potassium. It gets rid of phosphorus. It gets rid of nitrogenous waste in the form of urea. You might see this measurement in your blood called BUN, or what some people call the BUN. That's another assessment of the filtration capability of the kidney, except that we don't really use that as much as the creatinine or the EGFR, because the BUN also varies with how much protein you take in. So if you have, let's say, CKD stage 2 and your BUN is 25 and it should be 10, so it's elevated, it also is affected by not only the filtration ability of your kidney, but how much protein you take in. So if, let's say tonight you decide to eat 6 hamburgers, or you decide to eat 3 steaks, or have 10 cups of yogurt, or whatever it is, egg white, sources of protein, your BUM will go up independent of what the kidney is doing. So it's not as reflective of the kidney like the creatinine is, even though the creatinine will also go up if you have more protein, because the creatinine comes from muscle. So if you eat more meat, or more fish, or more yogurt, or more egg white, all things that have protein in them, your creatinine can go up. Usually it's muscle, it's not egg white. But it doesn't tend to change as much as the BUN does. So we use that. So we also not only look at the blood, but if a patient comes in with an abnormal creatinine or a drop in their EGFR, and they're a certain CKD stage, we will also look at the urine. We don't look at the creatinine in the urine as far as the filtration, although we do look at the creatinine for other things, but we'll check the urine for two other things. One is blood, and there could be frank blood in the urine, or there might be blood under the microscope. The urine can look yellow, completely normal, but when we look under the microscope, we will see blood cells there, and that gives us a potential clue as to what is damaging the kidney. The fact that the creatinine went up and you have a certain EGFR, or you're a certain CKD stage, doesn't tell us anything about what the cause was. There's hundreds and hundreds of reasons why those end results can occur. The creatinine going up and the EGFR going down are the end result of multiple hits that the kidney gets. The most common cause of why the kidney becomes abnormal is diabetes. Talk about that in a minute. So as I say, we look at just talking about what the doctor does if they want to get a bit more clue as to what's going on with your kidney, why you have an abnormal EGFR, why the creatinine went up. They'll look at the urine, they'll look for blood, and we also look for protein. The normal kidney has very little protein in the urine. And as the filters that are called the glomeruli get diseased, they leak more protein in the urine. They should be retaining protein in the blood. They shouldn't be letting it through. So anything coming through the filter will end up in the urine, like blood, excess blood, if it gets through the filter, or excess protein. It's just like a filter in your bathtub. It can either leak things excessively, or it can get clogged up. Now, diabetes tends to clog the filters, or you can think of it like that conceptually. That's why it happens to be the most common cause of why the kidney doesn't filter normally and why people go on dialysis. If you go to any dialysis unit or any kidney transplant program, statistically 50% of the patients ended up there because they had diabetes. Now, there's 2 types of diabetes, type 1 and type 2. Type 1 diabetes, around 40% of those patients get kidney problems. Tends to correlate with eye problems too. They get retinal problems. They can get bleeds. The blood vessels in the eye can bleed. They tend to go together, the kidney and the eye problems. 40% of the patients end up with that result. 60% of patients with type 1 diabetes have no problem with the kidney. Why that is not clear. Usually takes about 18 years after the initial diagnosis. Type 1 diabetes is due to a lack of insulin. So you have a 14-year-old kid who suddenly starts complaining of drinking a lot and peeing a lot. They were fine last week, and now they're going to the bathroom 20 times a day, and they're drinking excessively, and they lose weight. That's how the typical presentation is. So that's type 1, and they have to get insulin. That's type 1 diabetes. Type 2 diabetes, which is far, far more common, is not that you have a lack of insulin, but the insulin stops working on your cells. And the most common reason for that is obesity, people who are overweight. And we have a big instance of people who are overweight in the world, and also those who are frankly obese. And that's the most common cause of why insulin doesn't work. As your weight goes up, a number of physiologic and biochemical changes occur in the cells. And even though your pancreas is putting out insulin nicely, it just doesn't work as well. So you get diabetes that way. And the treatment is to lose the weight, which will return things to normal. Unfortunately, the hardest thing for a human to do on this planet is to alter their food intake. You can go to dietitians, you can go to a doctor, you know in your head you should do it. People just love food. We evolved to love food, and we evolved to eat. And so typically when a patient comes into the clinic and we tell them, which they know already, they need to lose weight, they'll go to the gym for a couple of weeks, or they'll change their diet for a couple of weeks, and then people cycle right back to what they used to do. It's really, really hard for someone to change their diet to lose weight. Hence all the new drugs that are out there that I'm sure you've heard about that help you lose weight. Is just because the intellectual part of your brain that knows to stop eating or eating as much is fighting the part of the brain that says eat, eat, eat. It's like the devil on one shoulder and the angel on the other shoulder. And usually the part that says eat wins out. It's just the way it is. You really have to achieve a level of anger or fear, two other emotions in addition to hunger, that make your brain alter what it's going to do. So unfortunately, because of overweight and obesity, we have this huge prevalence of diabetes, and it is the most common cause of kidney disease. We could rid the world of half the there's 620 or so thousand people on dialysis right now. We could rid half of the dialysis in the United States by stopping obesity and overweight, and we would need half as many kidney transplants. Now, diabetes isn't simply a kidney problem. What diabetes does, everybody knows it has something to do with blood sugar, but that's not the issue. Diabetes ruins your blood vessels, and one of the goals of having a nice, healthy life and living till 120, if possible, is to keep your blood vessels perfect. Why is that? Well, every part of your body needs blood, if you want to think about it simplistically. And we have miles and miles and miles of blood vessels that allow all the nutrients and oxygen to get to all the trillions of cells we have in our body. Our heart pumps the blood out, and it gets distributed to all the cells. And if you've got abnormal blood vessels, you're not going to be perfusing your cells normally. So people with diabetes who have abnormal blood vessels not only don't perfuse their kidney, but they also don't, the coronary arteries in the heart get abnormal, and they can get heart attacks, or the blood vessels in the brain get abnormal. You get a stroke, but it affects all the organs. It's just the ones people talk about are heart attacks and strokes. Now in the kidney, not only does the kidney not get blood like it should if the blood vessels are abnormal, but there's a second hit in the kidney, and that is the filters that I talked about. The glomeruli, that is the G in EGFR, they get plugged. It's like your bathtub with the filter in your bathtub filling up with junk, and you can't now get rid of the water in your bathtub. And the same thing happens in the kidney. And so the kidney gets two hits. One, it doesn't get the blood flow, and secondly, the filters all get clogged up. And if it gets bad enough, then your EGFR is going to decline from 100 down to less than 15, and you're not going to be able to sustain normal health without renal replacement therapy. So drug companies know it's a multi-billion-dollar market and are working on multiple drugs and that sort of thing. We have some new drugs that are out there, the so-called SGLT2 inhibitors. They work. They're one of the lights in nephrology in the last couple of years, because they seem to work not only in slowing down the rate of progression of the filtration abnormality, or again, saying it another way, preventing your creatinine from going up as quickly, or saying it another way, preventing your CKD stages from getting higher and higher. So all saying the same thing. There's no new ideas. It's just a different way of saying each of those things. They do that, and with the ultimate goal of keeping you off dialysis or getting to CKD stage 5. where it's imminent that you're likely going to need some renal replacement therapy. But it also looks like they may work in a number of different diseases that affect the filters, not just diabetes. So they're sort of exciting new drugs, and people are working on all sorts of approaches. The ultimate goal is to stop the progression of kidney disease due to diabetes. The sad part is if humans were capable of cutting their food intake down such that they would be at their ideal weight and look like they looked when they're 70, like they looked when they were 18, then we wouldn't be talking about this. And in fact, in the clinic, I try to encourage people. I say to them, get a picture of how you looked when you were 17, 18, blow it up and hang it in your bedroom and look at that every morning. And that hopefully would be at least what you can get to a little bit. Try to get there. Because it's all preventable in many cases. And it's just very sad that we need to create pills, and it's such a hard thing for people. But the reason it's so hard is we evolved to eat. Food was scarce when when Homo sapien came onto this planet 100,000 years ago or more. Food was scarce, and those that could find the food and those that could not metabolize it quickly got to live. Now we have just too much food. We don't even have to walk to get food. We have a fridge full of food, and it's very hard for the human brain not to open that fridge repeatedly. Now, the problem is that our appetite is also coupled to when we eat. So if you're eating 4 times a day, you're going to be hungry 4 times a day. When the brain gets used to the food coming in at a certain time, it will then anticipate that by creating hunger. So either the less often you eat in a day, or if you can, cut back on the food you eat. Try to evangelize the world and your friends and your family. And there's an old saying, you should never leave a meal full. You should leave every meal hungry. And if you leave every meal hungry, you know that at least you're potentially on the route to losing weight. But as I say, it's an extremely hard thing to do. Now, another common question we get asked is, how much water should I drink? I can't tell you how many times people either think of that or ask that, not just with kidney disease, but just in general. Should I drink a glass a day, 4 glasses a day? And it's the most confusing thing out there because you get 20 million different answers from 20 million MDs. And the reason you get those confusing answers is because there is no good answer. There is no good data telling you in general how much water you should drink. And any MD that tells you how much water you should drink, you should ask them, what are you basing it on? In fact, anything you hear from any MD is, show me the data. Don't have this, don't believe things on faith. Ask them for a peer-reviewed article that they can refer you to. And you read it. And if you have any questions, you can ask someone who you think knows more about it. But you should always have data backing up whatever you're told, if you have the courage to ask. And if they don't like it, then you're going to the wrong MD. I mean, anyone who's not humble with you, remember, you're the customer. You're the one who has the problem. And if they're not kind and they don't have empathy when they see you and they don't feel for what you're going through, then you should try to see another doctor. If they get angry or they feel you're talking inappropriately, then you're seeing the wrong person. So as far as the water, it's a little bit complex, because when you ask how much water I should drink, there's this thought that the water stays in your body. In fact, every time you drink, your kidneys recognize what you drank and they're peeing it out. So the water you drink stays in your body for a very short period of time. In fact, you can drink up to 12 liters of water a day. So imagine a 2-liter Coke bottle. Imagine 6 of those. You can drink that in 24 hours. Actually 7 of those, up to 14 in some people, 14 liters. And your kidney will recognize it and just pee it out. You can do the converse experiment and stop drinking altogether. And the kidney will cut back its urine output until it doesn't go to 0, but it goes to a very, very small amount. So the concept is that no matter what you do on the intake side, if you have normal kidneys, they're going to pee it out. So the question is then becomes a little more complicated. How much should I drink then? Sort of, if you think about that, has a number of different subtleties. One is how long is the water staying on board before the kidney pees it out? And during that time it's on board, is that going to do anything for me? And then the second thought is, well, maybe I should make my kidneys work by taking a lot of water, and maybe it's good for the kidneys to I'm not thinking so much about the water staying inside me and doing something. I'm thinking more about making the kidneys pee. Maybe that's good for me. So all these questions are complicated, and people aren't sort of precise as to what their questions are, and the doctors aren't precise in letting you know what's going on. Coupled to that complexity is that when the kidney has a disease, it cannot excrete 12 to 14 liters a day, and it cannot cut back to zero when your intake decreases. So it makes the question even more acute because the kidney can't modulate with your intake. And then there's another concept is in that, what if you're an athlete? What if you're losing a ton of water? Or you're someone who sweats a lot. You have what's called hyperhidrosis, and these people can lose liters of water a day just from their skin. So there can be what we call extrarenal water loss, either because you're exercising or you sweat a lot, and that then has implications as far as how much water I should drink, because there you're not thinking of what the kidney can do, but you've got this inappropriate water loss. Or if you're vomiting all the time, you have diseases that make you vomit, or you're someone with diarrhea all the time, you have this water loss, either through skin if you're running, or diarrhea if you have gastrointestinal issues. Even for a short period of time, the question applies, not necessarily chronically, how much water should I drink, but how much water should I drink when I go for a run, or how much water should I drink? I've been vomiting for 2 days. So these are complicated questions. But in general, the safest thing as far as answering the question is, don't drive the system unless you have the vomiting, the diarrhea, or the sweating. If you have that, yes, drink more than normal. And what is normal? Normal should be when you're thirsty. That's what the answer really should be. Drink when your brain tells you need to drink, not the intellectual part of your brain that says, I need to have 6 cups of water a day because I was told to, or I read that that's good for my kidneys or good for me. There's no data for that. Drink when your brain says you need to drink. That's the safest thing, especially if you have kidney disease. The only time the intellectual part of your brain should come into play is when you anticipate a run where you're going to lose a lot of water, and you can't rely on your thirst because you're running. You don't have access to water. So you're putting water into your body in an anticipatory sense. You're anticipating the need. And you don't wait till after the fact or when you feel thirsty, because you don't have access to the water, or drinking will affect your running, or whatever. Or when you have a gastrointestinal virus, whether it's a kid, elderly person, whatever, you want to give enough fluid to prevent becoming dehydrated. In medicine, we distinguish dehydration from volume depletion, which, the lay public doesn't use the word volume depletion. They use the word dehydrated. In medicine, we distinguish the two. Dehydration is pure distilled water loss. Volume depletion occurs when you lose salt with the water. And that is exemplified by, let's take the example. You lose a liter of pure distilled water, and you lose a liter of vomiting. Both patients lost a kilo, the same amount of weight. Okay. The one who lost pure distilled water, there are diseases where that occurs, versus the vomiter, both lost the same amount of weight. The vomiter is the one that's going to have the most consequences medically. They'll have the lower blood pressure. They can faint when they stand up. They have a faster heart rate. Whereas the person who lost pure distilled water is fine in general. And that's because we think in medicine of where the fluid came from. So there's fluid throughout all our bodies, and it's in different compartments. It's like different apartments. There's 2 or 3 liters of water in your blood vessels, and there's a total of 18 liters outside the cells that include the blood vessels. But there's 24 liters of water inside the cells. So in a normal 70-kilo person, there's 42 liters of water. distributed in all these compartments. When you lose a liter of pure water, or you drink a liter of pure water, that goes into the 42 liters. Very little of it goes into your blood vessels, turns out. So when you drink tonight a liter or 2-liter bottle of Coca-Cola, let's say you wanted to do that for some crazy reason, those 2 liters would be distributed into all the water in your body. Very little of it is going to be in your blood vessels that the kidneys can see. In fact, it's about a 0.15 liters. It's about 150 milliliters. Whereas if you drink a liter or 2 of salt water or Gatorade, much more of that stays outside the blood vessels and will affect your kidney function and your heart function. And if you want offline, just email me and I'll talk about that at much greater length. So we distinguish not the volume of what you took in or lost, but what it was composed of, because what the ions and the amount of salt in that water determines where that water is going to be distributed. It's like saying, let's say your car is your body. And let's say I take a hose and I pour it into your car. It'll go throughout the car, the trunk, inside the car, everywhere, if it's pure water. But if I had a hose that could pour Gatorade into your car, it would only go into your trunk. Not because you pointed it there, but because of the biology and the physics involved, which we can get into separately. So where the water goes depends on the composition of the water. That's why runners and people who are sweating a lot or people who have diarrhea either drink salt water or Gatorade, because the water stays, more of that water goes into their blood vessels than if they drank just distilled water. So that's an important consideration. Now that is important not just for runners, but when you get older, and by older, I mean 85 or 90. I don't consider people in their 70s old anymore. That changes all the time. In the future, we're going to have 150-year-old patients with 125-year-old nurses with 180-year-old doctors. That's what, every decade, what is considered old goes down. But in an elderly person or in the geriatric population, however you want to define it, patients lose the ability to modulate their blood pressure normally. And particularly when they stand up suddenly, or people who are on blood pressure medications. And that's very important, because if your blood pressure suddenly drops when you stand up, or just in general, if it's low because you're on too much blood pressure pills, you run the risk of fainting. When the brain isn't perfused normally because the pressure drops, it shuts off, allowing you to fall to the floor in a gravitational field. And that's an important reflex because it allows your pressure to normalize again and perfuse the brain. That doesn't work so well in the space station, in outer space. When you can't faint to the floor when you're in the space station, but on the Earth or in a gravitational field, when the brain doesn't get blood, it shuts off the signals to your legs. The muscles stop working, you fall to the floor, and you wake up again. But the problem is when you're 80 or 90, if you hit your hip, you're going to fracture your hip, because I'm sure many of you have heard of many people who are 80, 90, or 100 who fall, break their hip, and that's a major cause of death. Once you fracture your hip, you go into the hospital. Now it's better than it used to be 10, 20 years ago. You get the hip replacement. Hopefully they get you out of the hospital quickly, but it's a major cause of staying in the hospital. What happens in a hospital? You get pneumonia, you get an infection, or you get a blood clot in your leg. I mean, hospitals are not great places to be if you're 80 or 90. You try to stay away from them. So it's the secondary things that occur when you've broken your hip and you're 80 or 90. Now, it can be confusing because, you'll hear of someone who, let's say, fell and the doctor says you broke her hip. The chicken and the egg, you should always think of. It's not so clear that the fall broke the hip. It could be that they had a microfracture in the hip bone initially, and then it finally broke, and then they fell. So it's not so clear when someone falls that it was the hitting of the pavement or the floor that created the crack. The crack could have occurred prior to the fall, making them fall. And that's something that's often ignored. In general, if you have parents or yourself or the elderly, you should not have hardwood floors. You should try to have carpets in as many places as possible, so that at least if someone falls in the house, they don't fracture the hip. And anyone who you know is using a cane, you should get rid of that cane. Canes are horrible. They're a major reason for, and unfortunately, many people don't want to be seen with a walker. And so they go through the stages of first accepting the cane, and then they go from the cane to the walker. Ultimately, either they choose to on their own for logical reasons, or spouse or sibling or son or daughter insists that they do it. After a lot of fighting, they finally agree. But the point is, a walker is much safer for someone who is either unsteady or they have a chance of fainting because of blood pressure problems, which is why sort of we're talking about this now. And you can't imagine how many people in their 80s and 90s are on blood pressure pills, and where that blood pressure is either not being treated properly, or could be treated more simply on less pills, because doctors tend to be aggressive. And if you're seeing someone for high blood pressure, the philosophy is not, in general, philosophy should always be do no harm, but especially in people in their 80s and 90s, we should be accepting higher pressures than in younger people. Just because as we're more aggressive, we run the risk of creating a scenario where they get up suddenly and the pressure drops excessively. Normally, in all of us, when we get up suddenly, our heart recognizes it, and we have all these reflexes occurring with our blood vessels that prevents the pressure from dropping. But as you get older, the heart doesn't respond as quickly, and the blood vessels don't constrict as quickly, and the pressure can actually drop for a longer period of time, or excessively, and that's when you can faint. So in an older person on blood pressure pills, it's really important, number one, in all people, to make sure that you're measuring the blood pressure at home. Talk about that in a minute. And if at a minimum, get up slowly. If you have to pee in the middle of the night or whatever, it's usually at night when it's dark that the problems can occur. First, sit on the edge of the bed, make sure you don't feel like fainting, then stand up, make sure you don't feel like fainting, and then begin to walk. So you do things in stages to be more careful. Plus the fact that you don't see as well in the dark, all these things. And the other issue is, as people get older, you get up more often at night to pee. I say when you're 60, you get up once or twice. When you're 70, you get up twice or three times. When you're 80, you get up 4 times. And in your 90s, you don't sleep anymore. You're getting up to pee every 2 or 3 hours. So it's just the lot of humanity. There's nothing to do about that. I tell everybody not to fight that. Question always comes up, how much sleep should I get? It turns out as you get older, you don't need as much sleep. I mean, psychologically you want it, but you're not going to sleep, like a teenager, 15 hours a day, just, starting at 2 in the morning and sleeping till the middle of the afternoon. You're just not going to do that. And it shouldn't bother you. The key is just accept it and be happy with it. So falling at night is a major issue. The other issue is polypharmacy. Not only do we see that in nephrology, but in general, not only do you pee more often as you get older, but you're taking more pills. So, you just can ask, how many pills is this 95-year-old person taking versus this 50-year-old patient taking? I mean, it's like night and day. And we call that polypharmacy. If you have relatives or friends or parents, the goal should be, every time you see the doctor, one of your questions should be, can I get rid of any of these pills? Not only should you know the pills, which a lot of people don't know, you should always have them handy on your phone or written down. And not just you, but your children should know, your spouse should know. There should be a bunch of people knowing what pills you're on. And your goal should be to try to decrease these, because doctors just don't deal with it. Every doctor looks after their own pills, and you're seeing, you know, a cardiologist, an endocrinologist, your primary care physician. I mean, there's many cooks involved, many chefs involved, and no one looks at what anyone else is doing half the time. So you have to take charge of your body and look after it like you'd look after your car. And you go in and you say, here's my pills. A lot of times they'll say, well, I'm not really dealing with this and not dealing with that. That's why it's important to have a good primary care physician. The primary care physician is the sort of hub of the wheel. They're the ones that should know your entire body, not perfectly, but know everything that's going on. And they farm you out to all the subspecialists. So they're sort of like the central pivot of looking after you. And if you don't have a primary care physician, an internist, and you're 70 or 80, you need to get one. Now, the problem with medicine nowadays is it used to be 20, 30 years ago, that primary care physician would see you not only in the outpatient setting, but when you got sick, they would visit you in the hospital. Now, forget that. You've got, you know, a primary care physician in the outpatient setting. You go to the hospital, you end up with a whole slew of doctors who never saw you before, and you have to give your history 50 million times, which is very frustrating. Or if there's a medical student or a resident, you have to tell them. So you're even for the same visit, you're telling 4 different people the same thing. That's sort of the world we live in now. But it's important that at least you have a good primary care physician in the outpatient setting who knows you well. If you're in your 70s, 80s, or 90s, make sure you're getting all your vaccinations. You know, don't get pneumonia if you don't need to. Pneumococcal pneumonia can kill you. And herpes zoster, I don't know if any of you had it, but it's very, very uncomfortable. So get your zoster shot. I won't talk about COVID with all the politics. I'm sure you've heard up to here with COVID vaccinations, and I'm sure there's varied opinions. So we won't talk about that. Get your flu vaccine. A lot of these things are preventable. Just, you know, I tell everyone, you look after your car better than you look after your body for some reason. But the body's a machine, and you can add years and years and years to your life. Most of the things we see are self-inflicted. People either doing things they shouldn't do or ignoring things. If you look after your body, at least you'll know the things that hit you are coming from the heavens above, not from anything you did, and that you can't control. But if you play your cards right, you can add years and years and years to your life. One of the big things, as I alluded to, was blood pressure. There's 70 million Americans who have high blood pressure in this country. And most of them don't even know it. They don't care about it because it doesn't affect anything. People don't like measuring anything. They like other people, you know, doing the job for them. But every one of you should have a blood pressure cuff, and every human being should know what their blood pressure is, just like you weigh yourself on a scale. Well, many people don't weigh themselves on the scale, but you should be doing that too. You should be knowing what your weight is. You should be knowing what your ideal weight is, and you should be changing your food intake to get down to your ideal weight. You should exercise too, but it's really hard to lose weight with exercise. It's really, really, really hard. It's much easier to cut your calorie intake down. And as I say, every meal, if you're trying to lose weight, you should leave the meal hungry. If you leave the meal hungry, there should be a big smile on your face. Then you're doing what you should be doing. If you're leaving the meal full, no. So make sure you have a good blood pressure cuff. The Omicron cuffs are very good. There's many different types. Just make sure that if you've had the cuff for a year or two, that it's giving an accurate reading. And the only way you know that is to bring the cuff into the doctor. I tell everybody, bring your blood pressure cuff into your doctor once a year. If you're measuring your blood pressure, you don't want to be writing down numbers that aren't accurate. It's like putting a thermometer in your mouth and it's reading the wrong temperature, or having a scale that's adding 10 pounds to your real weight. Why would you want to do that? Well, it's the same with the blood pressure cuff. It's not going to be perfect, but you want to know that it's very close to what the blood pressure machine is in the doctor's office. Now, there's a matter of faith. You're assuming that the blood pressure machine in the doctor's office is correct, but that you can't do anything about. So you're just basically comparing it to that. Now, if it's not accurate, then you got to get rid of it. There's no way of changing the calibration on your blood pressure cuff. Now, some people say, well, let's say I get 130 in the doctor's office and mine's giving me 120. Can I just add 10 to what it is? Well, you can't do that because you're assuming it's what we call mathematically linear. That means if it's 110, you can add 10. If it's 120, you can add 10. If it's 130, you don't know that there's a linear relationship like that. So the best thing is just get rid of it. They're only $50, $60. I realize fully well for some people that's, more than they want to spend. But if you think about it, you go out to eat, you're going to spend 60, 70, 80. So don't go out to eat once and you'll buy yourself a new blood pressure cuff. They're not that expensive. You don't have to get yourself something fancy. A lot of them couple to your iPhone. You don't need anything like that. Apple has been trying to work for years on the Apple Watch, coming up with a way of measuring blood pressure. I don't think it's ever going to be as good as measuring it with a cuff. I mean, maybe someone will think of some way of doing it that they haven't thought of yet. What you can get with the Apple Watch is your cardiogram, which is really new, important information, especially for people with arrhythmias. And there are people with kidney disease who have arrhythmias. And so it's important to know, what's going on there, because that can affect your blood pressure also. So the other thing about blood pressure, if you are measuring it, as I say, the kidney controls your blood pressure. So it's one of the things nephrologists look after. The problem with blood pressure is it's sort of like, a bunch of mice trying to eat the cheese. Blood pressure is looked after by primary care doctors, endocrinologists, cardiologists, nephrologists, and it's really confusing to the patient as to which doctor they should see. Plus, each one may treat the same high blood pressure differently with different pills. So it can get really confusing. And a common question is, doctor, who should be looking after my blood pressure? My cardiologist tells me this. So that you need one cook. You need one person baking the cake. And you should insist on that if you can with your primary care doctor if it becomes confusing. But the key point with blood pressure is, number one, or one of the key points, is that the number varies throughout the day. It's like the weather. It's never the same. And I'm talking about normal people. So it fluctuates throughout the day, not because your blood pressure cuff is giving you crazy readings. It truly changes throughout the day. It's called diurnal variation. There's a normal change with time in a normal human. It tends to start peaking around 2 or 3 or 4 in the morning, reaches its maximum a couple hours before you get up, stays high, and then throughout the day falls again. You can look online, you can Google the normal diurnal variation. So that brings up an important point. You're going to get a different number depending on when you do the measurement. So that's one point. Secondly, when you get high blood pressure, you can get high blood pressure not throughout the day, but only at certain times. You may be a type of person whose blood pressure is highest in the morning, but the rest of the day you don't have high blood pressure. Or you may be a person with high blood pressure where the blood pressure is highest in the afternoon. That has two thoughts that come after it. Number one, how are you going to know that if you're only measuring it once a week, randomly? So think about it. You want to know what the weather is outside today, but you're only looking at what the weather is on your phone once every 2 weeks and randomly, not even in the morning versus that. So that clearly is a crazy thing to do. So you need to know what your blood pressure is at least 3 times. Measure in the morning, afternoon, at night. Now, we don't know what it is at night when we're sleeping, unfortunately, but it could be high in the middle of the night. So, but at least for half the day, know what it is. Number 2, it depends on what position you're in. Blood pressure is not the same lying, sitting, or standing. So not only does it vary throughout the day, but it varies with whether you measured it lying in bed, which some people like to do. Some people like to do it sitting. Very few people like doing it standing. But it will be different. And so you need to be aware of what your posture was, or just measure it sitting all the time. It's far easier. You don't have to think about it. So when you first want to address the question, what's my blood pressure? You measure it 3 times a day, and you measure it sitting. Now, why am I saying you should do it? Because we care much more about what you get than what it was in the doctor's office, because there's something called white coat syndrome. Every time you see a doctor, your blood pressure's, 20 or 30% higher. Just from the anxiety or being afraid. Most humans don't like, obviously, being in the presence of a doctor, or the whole thing creates anxiety, or afraid of what you're going to find out or not find out. It's very scary. So we want to know what your pressure is prior to seeing the doctor, because that's what we're treating at home. We're not treating your blood pressure when you come into the office. We want to get your blood pressure normalized in your daily life at home. So it's very important to get a good feeling of what your blood pressure is. You can keep it on an Excel sheet or write it down on a piece of paper if you're not familiar with a computer, but you should keep an accurate log if you're told your blood pressure is high, or just that you want to know. Intellectually, you want to know. And then when you see the doctor, you bring in your log and show them. It's irrelevant what you are in the office. Every doctor knows, or should know, that your blood pressure is going to be higher than what you bring in. And every good doctor will not base any treatment on what it is in the office. Now, the other thought is the treatment. So let's say you have your log, you brought it in, the doctor says you have high blood pressure, and you say, it seems to always be higher around supper time. Well, a good doctor will not only treat you for high blood pressure, but will give you the type of pill and when you take the pill, which is many times forgotten by most doctors, to treat the high in the afternoon or dinner time, whenever it was, but not lower it below normal the rest of the time, especially if you're 80 or 85, where you can actually faint if it's too low. And that's something that needs to be worked out. So hopefully, you hope, as a matter of faith or empirically, when you bring in the numbers, that it'll be a pattern that repeats. And usually it is. It's not something that fluctuates randomly. If you're high in the afternoon, you're going to be high always in the afternoon, unless you get some new disease process or something. But if everything stays status quo, that will be your pattern. The doctor should ideally give you the pills for that high in the afternoon, because the pills have different durations of action. They start working and they stop working, and they peak working at different time frames depending on the type of pill. So it's of no use to lower the pressure in the morning when it was already normal, and lower it below normal, but in the afternoon you didn't do a thing. And the only way you could know that, if the doctor gave you the right advice and the right prescription, is if you measure it and you say, look, now my pressure in the morning is 80/60, and in the afternoon, it dropped a bit, but I'm still high. That's inappropriate treatment. And unfortunately, it goes on all over the place all the time. So you just have to be aware of that. And anyone you know who has high blood pressure, anyone you know who's measuring their pressure, please teach them. The other thing that affects pressure that you can do on your own, independent of pills, is your salt intake. Salt causes water to be retained in the blood vessels, and it's like filling up the pipes in your house with more water. The pressure is going to go up. The same thing occurs with salt. Remember, if it's just pure water, as I mentioned, that gets distributed throughout your 42 liters of water, so it doesn't affect the blood pressure as much. But if there's salt with the water, the salt causes that water that you do take in to stay more outside the cells, and more of that is in your blood vessels, and that's what determines the pressure, the amount of volume in your blood vessels. That's one of the determinants of the pressure. It's just physics. There's nothing unique about the human body. So the less salt you take in, the lower your blood pressure. Now, some people, even though they're on a very low salt intake, still have a high blood pressure. So we say, okay, are you adding salt? No. Well, look at all the food you're taking in. What is its salt content? You say, I've gotten rid of all that too. And they say, well, okay, there's high blood pressure independent of the salt intake. Now, it doesn't mean the salt wouldn't affect it. Even if people still have high blood pressure when they're on a very low salt intake, doesn't mean the salt's not doing anything. They've helped it. It would have even been higher had they gone on a normal salt intake. So the lack of making it better completely doesn't mean it's not having an effect. Salt affects the blood pressure of everybody. Now, we care about it with kidney disease because it isn't just the intake. The kidney is the organ that gets rid of the salt. So just like the water you take in, the kidney recognizes the water, you pee it out. In that urine is salt. So if you had salt today, All the salt you took in today is coming out of your urine. The kidney recognizes it and gets rid of it. It doesn't get retained in your body. All the potassium you took in from the bananas and the fruit you're going to eat, the kidney recognizes the potassium and gets rid of it. So we care about the salt intake, especially if you have abnormal kidney function. If you have CKD3 or 4 or 5, the kidney can't get rid of the salt that you took in as easily. So even though you're cutting back on the salt, the kidney isn't able to get rid of that lower amount even as easily. And so you retain the salt longer and your blood pressure stays higher longer. If you have great functioning kidneys, you can take in more salt without it affecting your blood pressure because you'll pee it out. So salt affects the blood pressure to a greater degree if you have an abnormal ability to get rid of it. Then as your CKD stages get higher and higher and higher, you're more prone to getting high blood pressure from the salt that you did take in. So that's an important point. The other thing that the kidney does, and after this I'll stop because I don't want to put you all to sleep. The kidney is very important for keeping your bones healthy. Now, why is that? The kidney makes the active form of vitamin D. The vitamin D you take in your vitamins, or I'm sure many of you are on vitamin D, that's not the vitamin D that does anything. That's not the active form. The kidney takes that vitamin D pill and turns it into what's called the active form. It's called 125 vitamin D. The form of the vitamin D you're taking is called 25 vitamin D. It's just the chemical name, but the kidney modifies it. That's the concept, and turns it into the active form. But that can't occur when you have CKD4. And as your kidney function declines and the kidney gets more diseased, the ability for the kidney to create the active form of vitamin D declines. And so you can get bone problems, et cetera, et cetera, et cetera. So it's very important that the kidney, that's one of the hormones that the kidney makes, 125 vitamin D. So the kidney is responsible for keeping your bones healthy, and we look at that too. Another important thing that the kidney does is it makes a second hormone, important hormone called erythropoietin. What is erythropoietin? Erythropoietin is the hormone that maintains your blood count, prevents you from getting anemic. It's also the kidney's responsibility. Now, the kidney doesn't make the red blood cells. The red blood cells are made inside your bone marrow, in the bone marrow. All the bones, the bone marrow is where all your blood cells are made. But the bone marrow needs to know how much blood to make so that we don't have sludge in our blood vessels. The bone marrow only makes a certain amount of blood. You might have seen that in one of your lab tests called hemoglobin or hematocrit. You might have heard of that. That's your blood count. Well, the bone marrow knows how much your blood count should be because it receives a hormone from the kidney called erythropoietin. And when the kidney is diseased, not only does it not filter, not only does it retain salt, not only does it not make the active form of vitamin D, it also doesn't make erythropoietin normally. And so you get anemic. The bone marrow doesn't know how to make the normal amount of blood cells, and your hemoglobin starts dropping, or if you want, the hematocrit, it's another test that they do. It's the same thing. It's an assessment of what your blood count is, how many red blood cells you have floating around in your blood. Now, patients, when they reach CKD5 and on dialysis, used to get severely anemic. And in the 50s and 60s and 70s, they were getting blood transfusions until Amgen cloned erythropoietin. And that's how they became a multi-billion-dollar company. They made their erythropoietin synthetically. And that became a drug that was given not only in kidney patients, but cancer patients also get anemic. So they are getting erythropoietin also. And so it's basically revolutionized kidney disease in the last 30, 40 years, the creation of the synthetic erythropoietin. And patients who are on dialysis get erythropoietin. Now, once you get a kidney transplant, that new kidney makes erythropoietin, so your doctor doesn't have to give it to you. But it's important to realize that that's another important function of the kidney, to prevent you from getting anemic. Now, the other thing that can happen with the kidney with calcium in bones is the kidney can sometimes actually have the calcium that is normally in your urine turn into a stone. And you can get, I'm sure, what you've heard of called kidney stones. And it's a very, not an uncommon thing. The reason it's important is the pain that you can get from the kidney trying to push out a stone is worse than labor. It's worse than giving birth to a baby. It's the worst, almost the worst pain a human can feel. And it goes from your back all the way into your groin slowly. And you're vomiting and you're screaming and you're all sorts of things. The kidney is trying to get rid of the stone, and it can only come out if it's less than 2 millimeters. If it's over 2 millimeters, it's going to stay. And then there's many different ways to get rid of it. It depends on the number of stones. It depends where the stone is, how the size of the stone, that sort of thing. But kidney stones is another common problem with the kidney. Now, that isn't a kidney with CKD. That can be that's a normal kidney. But the kidney itself, normally the calcium in our urine doesn't make a stone. It's a matter of faith that, many women are taking Tums too, which is a lot of calcium. You don't get problems with stones unless you're taking, in a normal person, a ton of calcium. But even some people on a normal calcium intake, the calcium comes out of solution and can create a kidney stone. And there's many different types of kidney stones. Some aren't made of calcium. That's a whole other topic and lecture. But the reason to know about it is if one of your friends or relatives, family members suddenly complains of pain in the back that's starting to go to the front, your brain should think, could that be a kidney stone? You take them to the emergency room and it'll be known or not known. They do an ultrasound of the abdomen. They can see it right away. So that's just sort of an aside that has nothing to do with CKD stages or that sort of thing. I'll just say that one of the issues that we face is that people aren't aware of what their creatinine is. Most of the American population doesn't know that their creatinine is elevated, or they have CKD, or their eGFR is low. Again, it's all saying the same thing. I'm not saying anything different when I say those three things. 1 out of every 8 people in a room or a party or anywhere you go has an abnormal eGFR. Or saying it another way, they have CKD 1 or 2, or saying it another way, their creatinine's elevated, and they don't know it. That's the key point. It's sort of a silent entity. And the reason is people don't feel anything. You don't start getting or noticing, assuming the doctor didn't do a blood test. These are people who don't have their blood test. I'm talking about what they feel. You don't get symptoms until your eGFR gets down to about 20, 30, that sort of thing. And what are the symptoms? They're not even anything that you would predict would be due to the kidney. What do they feel? They start losing their appetite, or they get nauseous. Now, how many people have told you in the last year they feel nauseous or lost their appetite? I'm sure the first thought in your head isn't, oh, you must have kidney disease. It's, oh, did you eat something at a restaurant, or you got a virus or something? The reason is those are far more common. But you have to keep in the back of your mind that severe loss of kidney function can also lead to nausea and loss of appetite. The other thing that happens is these people get abnormal taste. The food just doesn't taste normal. So one thing we tell patients who are on dialysis or who have CKD stage 4 or 5 and who complain, it's not an uncommon complaint that the food doesn't taste. There's all sorts of recipes or things you can do to add more spices, but it's a major problem in nephrology. Not, let alone you don't feel like eating and you feel nauseous. Now the food tastes horrible. Another thing they get is abnormal sleep. And you can imagine these people are, many of them 70, 80, 90, they're already not sleeping. And now they have even worse sleeping habits. The other is depression. There's frank depression, where they're depressed just because of what happened to them. I mean, you go through all the stages of disbelief, anger, bargaining with God, all these things, until you accept it. There is true depression. And then there's also psychological changes that can mask, can look like depression, even though they're not depressed. And so it's incumbent on a good nephrologist or primary care physician to distinguish whether a patient is truly depressed or whether they're not. And there's objective tests you have to give the patient. They have to fill out questionnaires. And the questionnaire accurately tells you whether this is something that's masking as depression, but it's not, versus true depression, because obviously you want to know, because you're going to approach those patients differently, different treatments, that sort of thing. So you want to make the correct diagnosis, and it's a big mishmash with patients really not knowing, either because the doctors didn't bother evaluating them, or they stop going to the doctor, these kind of things. We have patients who skip their dialysis and skip their treatments, especially the teenagers. And they, that's a whole other problem that we have, non-compliance, just because of either their age, teenagers think they're immortal, or people just being depressed, or many reasons why people don't, adamantly go to the doctor. So I think I'll stop there. And if any of you still have energy, I'd be glad to take any questions you have. And those of you that maybe don't want to because it's too personal, please reach out to Leslie or my office, and I'd be glad to talk to you separately with a Zoom or on the phone to address any worries or questions you might have, or any way I could possibly help you. But the purpose of these lectures is to educate the public, with the hope that you will go out and educate people on kidney disease and how to look after your bodies and prevent some of the common things, especially being overweight, and the diabetes is the big elephant in the room. So I think I'll stop there. Does anyone have anything they want to say?
There were a couple of things in the chat, both relating to the water, drinking water. And one of them was mine. If you're taking medications that cause dehydration,
yes,
should you be increasing water? And is there the other question that the other person had is should you be drinking like Gatorade? Is that something, or is that bad for your kidney?
Yeah, those are two excellent questions. So I alluded to it somewhat when I was talking about what's called extrarenal water loss. So if you're running and you're sweating, or you're vomiting, or you have diarrhea, or you're taking a drug. Sorry, you froze for a minute. Were you able to hear? You were still able to hear, or should I? Okay, I think you're muted.
Yeah, no, I couldn't hear. I froze for a second.
I'll start again. So I said that was an excellent set of questions, but it falls into what I was talking about before. If you have no water loss that's excessive, you can go by your thirst. However, if you're a runner and you're losing sweat, or you have vomiting or diarrhea and you're losing water, or you're on a pill that makes your kidney lose excess water, yes, you should be compensating for it. If it's not excessive with the kidney question you asked, whether you're on a diuretic or other pills that make the kidney pee out more urine, you'll get thirsty. So as long as your brain is normal and your thirst center is normal, you don't have to rely on your intellect or anything to anticipate it. You will feel thirst more often. So if your thirst center is normal, which it is in most people who are on these pills, then you don't have to worry. If you're not sure, or you don't want to take a chance, yes, you can compensate by drinking 20 or 30% more. You will know whether it's appropriate or not by your weight. Your weight is a fantastic assessor of how much water you have in your body. Now, from day to day, it can vary if you didn't go to the bathroom and you have some stool there, or you just ate. But on the average for the week, the day-to-day weight is an assessment, especially if you weigh yourself first thing in the morning after you've peed, and you do it without clothes. That's a pretty good assessment of how much water you have in your body. And if you're taking a diuretic and you're losing more water than you're taking in, your weight's going to go down. It has to. Water weighs. Every liter of water you lose a kilo. So if your weight is staying the same, given the fluctuations up or down a pound, that sort of thing, but if the average is really, the same, then your input and output are equal. You don't have to worry. So again, I tell everybody to weigh themselves, not just to know, which I didn't mention, but what your question alludes to, the water intake and output, but also obviously in the long term to try to lose weight if you're overweight. So yes, in general, you can still, if you're on a diuretic, just use your thirst as a mechanism for knowing, and then your weight is sort of a second way of doing it. If you're worried, increase your intake by 20-25%. If you're over what you need to, your kidney's going to recognize it and pee it out anyway. You're not going to retain it. Remember, the kidney recognizes everything you take in. So if you go overboard, you have up to 12 liters a day that it's going to pee out if the kidney function is normal. Now, if you're talking about someone with abnormal kidney function to begin with, like CKD3, 4, 5, then the question is more complicated and subtle. They still have the thirst, but if you go overboard with the intake, you didn't guess right because you're trying to compensate for the diuretic, then you could start retaining water because the kidney just can't rid of the excess that you're giving that you shouldn't have given. And you'll know that because you're gaining. You'll know that. You'll see yourself gaining weight. Now, your second question about what kind of fluid you should take in, whether it should be electrolyte water. I mean, there's so many different choices out there as even what electrolyte water means, because the concentration and the quantity of the electrolytes in that water varies. You know, it's not like one substance, you know, like you're drinking pure distilled Lake Arrowhead water. There's electrolytes in tomato juice, which some people like to take to make up for the salt loss. There's electrolytes in Gatorade. They all have different amounts. And so in general, again, if you have normal kidney function and you're trying to replace what the diuretic is doing, if just that question alone, when you have a diuretic or these other Farxiga, these kind of things, you're not losing just water, you're losing electrolytes. And so you really shouldn't be replacing it with pure water. You should be replacing it with electrolyte water. Again, if you go overboard and take too much of it, not only will the kidney recognize how much excess water you took in, it'll also recognize the excess potassium, sodium, chloride, all the other ions, magnesium, calcium, and it'll get rid of exactly what it needs to get rid of to maintain your body in the same exact initial state as it was. The kidney recognizes thousands of things you take in and make sure that whatever you take in comes out in your urine. The urine isn't just water that's yellow. The urine is a complex chemistry in there. And the overall concept is, if someone says to you, just in general, which is sort of off topic, what is the purpose of the kidney? The purpose of the kidney is to keep the chemistry of your blood constant with all the thousands of different chemicals in the blood, despite the fact that 3 times a day, you're significantly changing your blood chemistry because humans eat 3 times a day. And it's like pouring, you know, this complex chemistry when you were in high school into a beaker that's already complex chemistry. But the kidney recognizes all the changes you're making and dumps it all in the urine. So it's the same thing here, except it's the opposite. Here, you're causing the kidney to get rid of excess water and excess electrolytes that's inappropriate for your blood chemistry. And now you have to make it up yourself on the input side. So just, you know, to answer the question simplistically, and it's a good question, if you alter the function of the kidney by making it do something it shouldn't be doing, like Farxiga or a diuretic, you yourself have to make it up on the input side. And since you're not measuring all the complex chemistry, it's not just electrolytes that are changing, there's many, many other things. You can somewhat compensate by taking electrolyte water. Ideally, you would recognize everything that these compounds are doing and exactly match what you should on the input side. But, you know, you go out of your mind, you'd be a chemist if you could do that. So yes, just you take the electrolyte water and go overboard, because if you go overboard, the kidney will get rid of the excess. If you go under, if you're too cautious, then you'll start losing weight and you could change your blood chemistry. So it's an excellent question and a complicated one, but in general, rely on your thirst, at least for the water part. The electrolyte part, you're just going to have to take in Gatorade or some other electrolyte water. And if you're over, your kidney will dump it. So I hope that answers the question. It's a very good question.
Yes, thank you very much.
Are there any other questions at all? I mean, basically, in general, we perturb our blood chemistry so much you would cry if I could show you what you do when you eat. You know, eating isn't just making hunger go away. Eating has the other effect of really perturbing the chemistry of blood. But we have this amazing organ called the kidney that recognizes almost the whole periodic table. It measures every single change you've made and has set points. It dumps everything that you've put into the system to keep the chemistry of your blood what it was prior to you eating. Now, if you don't eat, you don't need kidneys, right? Because you're never going to perturb your blood chemistry. I mean, you're not going to be a happy person if you do that. But because we eat 3 times a day, the kidney 3 times a day in general is bringing your blood chemistry back to normal, assuming that you have normal kidneys. That's what happens when you don't have kidneys. So people on dialysis, number one, they don't pee. So they don't have the problem of an 80 and 90-year-old getting up 10 times a night to pee. That's nice. But the problem is everything they put into their system perturbs their blood chemistry severely. And that's why we have to dialyze them. So on dialysis, we're basically returning their blood chemistry to normal because their kidney can't modulate the chemistry anymore. So if they drink 2 liters of water, they gain 2 kilos. If they drink 5 liters of water, they don't pee. They gain 5 kilos. So we have to remove 5 liters on dialysis or 2 liters. We know how much to remove because we weigh them when they come in for the dialysis treatment. We see how much their weight changed from the previous time they were dialyzed. So we know exactly how much water they drink.